And welcome to the Dr. Bob Show. You know, I frequently tell people you've only got two ears, so take care of them. Are you worried about your hearing? Maybe you've been at concerts where the music has been too loud. Maybe you've been shooting a weapon and the loud noises. Maybe you've got a cell phone and you've got speakers and they're too loud and you hear ringing in your ears and people ask you, maybe you need to get your hearing checked. We'll be spending most of this show talking about hearing and hearing loss and what you can do about it and what causes it. My guest is Dr. Nick Panella. Dr. Panella is a board-certified ear, nose, and throat physician, and he'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about women and heart disease and some new findings. And if we have time, we'll be talking about that old friend of ours, obesity, and the problems that it can cause. A lot of information for you. You'll want to stay tuned. We're talking with Dr. Nick Panella, board-certified ear, nose, and throat doctor, and we're talking about problems with hearing, predominantly adults. Nick, welcome to the Dr. Bob Show.
Thank you. Thanks for having me.
How common is hearing loss in adults?
Hearing loss is interesting because if you looked hard enough, we probably all have some degree of hearing loss. And the question just becomes, at what point is it causing you symptoms, and at what point would you really want to go and have it tested and have it checked out? We all lose hearing with age, and by age, I don't mean what people sometimes think, which is, 70, 80, 90. We all lose hearing probably starting in our 20s or even our 30s, and we start to have these incremental decreases with age. And so it's one of those things that can affect almost anyone and probably does affect a large majority of our population to some degree.
So if we take a 20-year-old, 30-year-old that's beginning to lose some hearing, but they don't realize that, are there things that they can do to protect hearing loss being more aggressive?
Absolutely, yeah. So with age, and especially now in the era of earbuds and loud music and lots of loud music at concerts, what we recommend is that people think about that more often. And you don't have to wear earplugs all day, every day, but there are situations that you may not necessarily associate with a dangerous level of hearing loss that can be encountered in everyday life. And so we recommend people are really careful at concerts, air travel, when working with power tools, about wearing ear protection, and then just using common sense stuff like when you're using your earbud headphones, just find a volume that's comfortable but not necessarily loud in terms of the way you perceive it.
Even at my age, I've gone to some concerts and I come out and my ears are ringing and it lasts for 8, 10, 12 hours almost the next morning. Is that damaging my hearing?
It can be. So that's something called a temporary threshold shift, which is just doctor speak. But what that is your body saying something was too loud, and so we've turned down the volume. And so for a couple of hours, sometimes even a couple of days, you can have this period where your ear is really kind of in the volume down mode because your body has reacted to that really loud, abrasive stimulus, and it's kind of shut all of the volume down for a little while. And so sometimes those can be permanent, but we also know that people that are having a lot of those temporary threshold shifts are probably more likely to have some long-term hearing damage from it.
So let's talk about hearing. How does hearing occur? I've got an ear.
Sure.
How does that manufacture sound?
So you probably get a little bias here because of the way I'm trained and what I chose to do, but I think hearing is one of the most fascinating things in the entire human body. So it kind of can be broken up into two rough parts. So the first part is the conductive or the mechanical part. That's where the sound waves that are floating through the air hit your eardrum. And your eardrum at rest should be just sitting kind of like a sail, just not moving, but just kind of hanging loosely.
Where is the eardrum?
So the eardrum is the thing that when your doctor looks in there with the otoscope, that's that little thin membrane that they're seeing, and it's a couple of centimeters down in there. So you can't see it unless you're looking in with the otoscope. But when the air sound waves hit the eardrum, they wiggle it just a little bit. I mean, you can't see that wiggle, but the sound waves just push it ever so gently. And then once it hits the eardrum, it wiggles the ear bones. Those are called the ossicles. And those three bones are connected to the more inner ear structures. And so that first part is the conductive part, where the sound waves turn into mechanical energy. And then the stapes bone, which is the littlest of the ear bones, shakes up against the cochlea, and that's where the sound becomes a conductive signal to more of an electronic signal. And just like an electrical wire that you have behind your TV, the electronic signal goes from the cochlea and into the brain. And so there's two kind of stages there with all of hearing, and there can be problems at either stage.
So if somebody has earwax that's blocking the ear, does that harm the hearing?
It does, and that would be more of a conductive problem. So if you've got the sound wave coming into the ear and it's hitting up against earwax, it's not going to hit the eardrum with the same velocity, and therefore, if you're fully plugged with earwax, you're going to notice that sounds are muffled.
And behind the eardrum, where those bones are, the three bones that move and wiggle because sound made the eardrum wiggle, what goes wrong with those? What can go wrong in that middle ear?
So if you've ever had a kid or an adult that had an ear infection and you had a bunch of fluid around those bones, they don't move as well when they're in fluid or in thick infection. And so that can cause that type of conductive hearing loss. Or more rarely, we can see problems with the actual bones. So there's a condition where the ear bones get something that's similar to arthritis, and those bones get kind of stuck. And so then the ear bone doesn't wiggle as well. That's something called otosclerosis. But it can be the same effect where the ear signal is not quite getting to the cochlea like it's supposed to.
Can otosclerosis, can that be fixed?
It can. It's one of the ear problems. Unlike a lot of types of hearing loss, it's one that's treated primarily with surgery. And what the surgeon does is they actually take out that smallest ear bone, the stapes bone, that's usually kind of hardened with some bone scar, and they put in a little titanium prosthesis. And the prosthesis is much more resistant to that hardening process and usually can wiggle a lot better.
And then after the bones, the third bone sits up against
the cochlea.
The cochlea.
That's,
what is the cochlea?
The cochlea is shaped like a little seashell. And what the cochlea does is it takes that mechanical energy, and then there's fluid inside of the cochlea. And the fluid wave is started with the energy wave from the bones. And then the fluid wave goes up through the cochlea, and all along the way, it's triggering little electrical impulses that fire to the brain.
And it fires through the hearing nerve, the eighth cranial nerve.
That's correct.
So anything can go wrong in any place during that.
Absolutely.
If somebody starts getting hearing loss that becomes obvious to other people, what are some of the symptoms that they have?
So most commonly, the things that we're seeing people for that we end up diagnosing with hearing loss are, number one, ringing in the ears. That's one of the first things that people will notice.
What's that called?
It's called tinnitus. It's often called tinnitus, but that's a slight mispronunciation, so it's called tinnitus. And that's when you have ringing in the ears. Sometimes it does sound like a high-pitched ringing. Sometimes it's more like crickets, or it's more of a dull roar.
When I'm on the phone sometimes, somebody's speaking too fast and I have to say, slow down. Is that a sign that I'm not hearing well?
It may be, yes. So if we have any decrease in our ability to take the sound in and have it come to our brain, then things like rapid speech or speech in noise situations, so that's the kind of the classic cocktail party effect, where if you're trying to talk to somebody face to face at a cocktail party and there's a lot of surrounding noise, any little degree of hearing loss will be really heightened at that moment, because your body will have trouble discerning what's the real sound to pay attention to and what's the background noise that you want to try to cancel out.
Has that got a big, long medical name for it, a doctor talk? Presbycusis?
Presbycusis is, yeah, that's a good way of, that's one of the ways that you could describe that. And it's very common seen with presbycusis.
And so that's when an old fogey gets in a restaurant and he can't hear the conversation across the table because of all the noise in the room. Can that be helped?
It can. It's luckily one of the things that responds really well to hearing aids.
So if somebody comes to the ear, nose, and throat doctor and they're questioning their hearing, are there tests that can be done other than just looking at the eardrum?
Sure. So when I see a new patient with what sounds like hearing loss, so let's say they came in because their ear was ringing, or they came in because their spouse has said, hey, he's really struggling lately. I listen to the TV on a volume of 7 and he listens to the TV on a volume of 22. That kind of story, my immediate goal is to determine where is that hearing loss coming from. And sometimes that's as simple as looking in the ear and finding a big ball of wax. Sometimes it takes a little bit more. So I could look in the ear and the ear looks normal on my exam. Sometimes I even use a microscope to look at the ear a little bit more carefully. And then depending on what I find, the next step is usually to get an audiogram.
An audiogram. And that's what we're going to be talking about when we come back. What is an audiogram? What does it really tell the ear doctor? How can it help you, the patient? When you get an audiogram, what's the information mean? You'll want to stay tuned. We're talking with Dr. Nick Panella, board certified ear, nose, and throat doctor. We're talking about hearing loss, about how hearing occurs, how the energy of sound goes into the ear canal where it hits the eardrum, wiggles the 3 bones behind it, they wiggle, and then that energy goes into the cochlea where sound is assimilated up in the brain. Things can go wrong at any place. And then we talked about physical exam followed by an audiogram. What's an audiogram, Nick?
So an audiogram gets into one of the interesting things about our field, which is that we overlap with another type of doctor. So the audiogram is done by an audiologist. That's usually somebody with a doctorate in audiology that's even more specifically trained in that type of a process. So what happens is I take the patient over to our audiologist, we have a little introduction, and then what they do is they play a series of sounds through special different types of headphones, and the patient simply says, yes, I can hear that, no, I cannot hear that. And as they proceed through the test, what the audiologist will build for me is a little pictorial representation, so just a little graph of what kind of hearing that patient has.
So what can that tell you? If you've got the audiogram where they've been able to identify certain levels of noise that comes through, what does it tell you, the doctor, about that patient?
So it's where the part of my job that it turns completely into pattern recognition. So there's some types of hearing loss that are just classic. So somebody with presbycusis, like you said, which is typically what we think of as age-related or noise exposure-related hearing loss, will have a very classic pattern where they have some decrease in high frequency, which is really high-pitched noises.
Is that the first thing that usually goes? High frequency
It is.
in most people?
That tends to be the hair cells of the cochlea that are the most sensitive to either noise exposure or to age. And so with time, those are the ones that tend to kind of drop off first.
So is that why I can't hear my wife real good sometimes, because she has more of a high-pitched, soft voice?
It might be, and it's the reason that we don't hear dog whistles. That's the very highest pitch, and it's the reason that little kids can hear these sounds that we sometimes can't hear at the very highest pitches.
So that's a common finding.
It is.
What else does it tell you? What other patterns?
So sometimes there's patterns that we call asymmetry. So that would be where somebody comes in, they say, I'm not hearing as well, and then I get an audiogram and one side hears very well and one side hears very, very poorly. And that might be more concerning for some other type of process. And so you have to, hopefully have somebody that can pick up on that and say, I think we'd like to get an MRI. And
MRI, what was that going to tell? What will that tell you?
So an MRI can be a picture that's taken of the brain or the nerves leading to the brain. And what that might show me is if there's any kind of a growth along that pathway, usually benign, but sometimes there can be a growth on the hearing nerve that can cause one-sided hearing loss. Most of the time when we look for that pattern, we don't find it, but we like to be safe because if somebody does have one of those growing there, we want to catch it where it's small, and so we can make some decisions about treatment.
If for some reason somebody is always involved in one side of hearing, like somebody shoots a gun and bang, it's closer to that ear, or in work they're by a grinding machine that it's, would that be asymmetry also, perhaps?
It certainly can. It's actually interesting with a gun. It's the ear that's away, that's not tucked down, because the sound comes from the muzzle. And so yes, we do see it in shooters. We do see it in people that had exposure. For instance, a military patient that has had exposure to an explosion on one side, but not necessarily is exposed on the other. So we can see some asymmetry that's just natural. It's just part of that patient. But when we see a very clear asymmetry, that's when we like to think, okay, well, let's get an MRI just to be safe.
So if somebody has hearing loss, what can you do to help that patient? And then we're going to talk how you can prevent, let's say at age 20 or 30, from getting hearing loss like that. But let's go right to, if you find an abnormal audiogram and the person has problems and they say, Doc, how's my hearing? And you say, well, it's sort of terrible on one side. They say, well, what can you do to help me?
There's a couple of options. So in somebody that just has the traditional both-sided hearing loss, higher frequencies in particular, that's usually a good patient for hearing aids, and usually on both sides. So we have tons of patients that are treated with hearing aids on both sides, and with the newer hearing aid technology, they do really, really well. So they can go back from somebody that was having trouble in conversation, struggling in mixed noise situations, struggling at the cocktail party kind of situation, and they can become very, very functional again. And so we're very encouraged by the results in those patients. There's also some patients that will identify a benign tumor in the eardrum or something along those lines. Sometimes those patients benefit from surgery and they don't need a hearing aid. And then there's other people that may benefit from a hearing aid on one side but don't need one on the other. So there's many different patterns of treatment for hearing loss. But in most cases, patients can be treated for their hearing loss, even if it involves the very most extreme, which is something called a cochlear implant.
Now, in the old days, a hearing aid was just magnification. So it increased the noise in the background and the noise of the person talking with you. How have they differentiated that? What have they done that makes the hearing aids more sophisticated?
Sure. So the interesting thing about hearing aids is that they're kind of marketed on all different ways. So if you went to Amazon.com right now, you can buy what's marketed as a hearing aid that is basically just a sound amplifier. It's a little microphone and it'll just increase the volume of everything around you. Probably there are some people that'll be a really good option for, but the vast majority of people's hearing loss is a little more complex than that. And so what a good audiologist does, again, not myself, but a good audiologist will do is they'll take the patient's hearing loss pattern and they'll look at it and they'll say, okay, you're kind of struggling at this frequency, but you're pretty good on this frequency. And so they will program the hearing aids specifically to amplify where you are weak.
So it's getting more and more sophisticated.
It is. And there's more and more patient control now. So a lot of them are integrated with apps. And so you might have an app on your phone that says, now I'm at dinner, and the algorithm or the program, that the software that's in the hearing aid will change so that it will now amplify the person right across the table from you rather than all the surrounding noise.
I've got a person that sits beside me in choir and he pulls out his cell phone, and I don't know if he's trying to make it where he hears the preacher more or he hears him less.
That's right.
So they have the ability to control different environments with hearing aids like that. How big are hearing aids? Do they fit in the canal or do they hook onto the bone?
So there's different styles of hearing aids. The most kind of universal style, and the style that the majority of our patients end up in, is what's called receiver in the canal, where they have a little piece that's in their ear canal and then they have a tiny tube that's clear. So it almost just looks like a little thin hair that goes up and around, and then the majority of the processing parts of the hearing aid sit behind the ear itself. And so it's something that, honestly, I'll see patients all the time and I won't realize until I go to do the ear exam that they're wearing a hearing aid. It's very, very subtle.
Yeah, to me that's cool. When the audiologist and the ear, nose, and throat doctor makes a decision on the hearing aids and they decide what's best for the patient, how important is follow-up?
Very important. And again, that's where a good audiology team is invaluable, because I see patients all the time and they say, hey, my hearing aid's broken, will you fix it? And I am clueless. That is not my specialty. But luckily we have a really good team of audiologists, and I will say, let me kindly show you to the person that can help you with that, because a hearing aid is not the same as a pair of glasses. You get your glasses, they're the right prescription, they're a good fit. You can use them for a while and they don't require a lot of messing with. A hearing aid is a little bit more of a complex instrument. It has a lot of different features and a lot of areas that can work well or not work well. And so close follow-up with somebody that's good at programming a hearing aid is essential to get a good result.
30 seconds. What can we do to protect our hearing?
I would say the number one thing would be careful with the volume of your headphones. The headphones are one of the things that we are seeing is arising as a big problem in hearing loss.
Can you predict that in the future a lot of the younger people are going to have trouble with their hearing later on.
Absolutely.
And if they can prevent that now, then they won't have to have a hearing aid later on.
Absolutely. I think that is a takeaway message for any young person or even middle-aged person watching this show. Be very careful with the hearing you have left, because even if you don't think you're damaging it now, it's the cumulative exposure to noise that ends up causing hearing loss.
Nick Panella, you're a great teacher. I love having you on the Dr. Bob Show. You've got a passion for what you're doing, and obviously you know a lot about hearing. Thank you for coming and
Thank you
teaching
very
us.
much. I appreciate you having me.
Great information. You only got 2 ears. Take care of them. Keep away from loud, abrasive noises that will damage your hearing. That's the message we want to take care of. And if you're having problems, see the specialist. Be sure that you approach it properly and get good advice. And now you're going to want to stay tuned. We're going to be talking about women and heart disease and our old friend obesity. What can we do about it? A lot of information. I want to thank Dr. Nick Panella. Wonderful discussion on hearing, the problems that can occur, and what you can do about it. Now, questions from you, the viewer, that I think will be important to your health. Question number 1. Dr. Bob, I'm 62. What kind of problems do women need to look for as concerning heart disease? It's a really excellent question. For many, many years, we always thought that men were the ones that had the aggressive heart problems. But then we began to learn that women actually had more severe heart problems. They just had their problems later on. So let's look and see what some of those heart problems are and what kind of symptoms that women have that men don't have. Men usually have classic pressure pain in the middle of the chest when they're having a heart attack. Women may have, with exercise, just really shortness of breath and just fatigue. They just don't feel good. Something is different. Something is abnormal. The heart is not pumping as well. When women get a heart attack, they have more problems getting better and having heart failure later on. When women get heart failure, they have a more difficult time with their heart failure than men do. When we measure heart failure, we frequently measure how effective the heart is at pumping out blood. And men, frequently that ejection fraction is low. And women, it can be normal, but they can still be having heart failure. And it's most likely due to the fact that the heart muscles are not being nourished as well by blood vessels that are deep inside the muscles to the heart. So women, be sure that you think about your heart and think about risk factors. Think about blood pressure, cholesterol, diabetes, sedentary lifestyle, obesity, all of those things. Because if we can look at the risk factors, you can improve your health and you won't have to worry about those heart attacks. Question number 2. Dr. Bob, what can I do about being overweight? It's a great problem, and it's a problem in the United States. We have an epidemic of obesity. When you look at pictures of people that are walking down the street, we see lots of people that are overweight. Their body mass index, their BMI, is over 30 or is between 27 and 30. That means they're overweight, and there's so much that we can do about that. When we're overweight, it increases the incidence of snoring and obstructive sleep apnea. It increases the incidence actually of having asthma. It makes it where we don't ventilate as good. We don't breathe as well when we're overweight. Our cholesterol goes up. Heart disease is increased. Blood pressure is increased. So if you're overweight, you need to get on a good game plan. And we talk about this in the Dr. Bob Show. You've got to, first of all, eat properly. Now, you don't have to eat like a bird, and you don't have to eat bird seeds. You just have to look at the foods you're eating, fruits and vegetables. You know, when you get in the habit of eating fruits and vegetables, you like those. Have a good breakfast. Incorporate some oats and some fiber and healthy foods for breakfast. For lunch, be sure that you stay away from fast foods. Take your lunch back, from home and make it fruit and make it carrots and make it vegetables. Don't make it sandwiches with mayonnaise and things that may harm your health. And at supper time, should be your smallest meal. So look at the plate, see how much you eat. Then we've got to get active. We've got to know that activity will help us lose weight. And so if you eat properly and you're active, you get those tennis shoes out, you get your Fitbit, you get your 10,000 steps or 15,000 steps, then it will lead you toward losing weight. The biggest problem, I think, is you can't cheat. No matter what you do, you have to follow that plan. So you may need a specialist, you may need a nutritionist, but know that obesity is one of the problems that will harm your longevity and your health. And that's all the time that we have. Remember, we need to be exercising 30 minutes, 40 minutes, 5 times a week. The more you exercise, the better off you're going to be, less stress, lose weight, blood pressure goes down. Eat properly, fruits, fiber, vegetables. Get 7.5 hours sleep. If you're not sleeping well, know that you need to find out why. If you're not sleeping well, is it because you've got pain? Is it because there's too much noise in the room? Is it the medicines that are keeping you up? Do you not know how to go to sleep? Do you not know how to rest before you lay down and go to bed? So learn how to sleep. And most of all, we like that laughter in your life. Be sure you giggle. Be sure you laugh a lot. Because the more you laugh, the healthier you're going to be.